Okay, we are recording. Let's go. Okay, hypoxia and ischemia. The blood vessels themselves are okay, but the pump is not working. So you have a patient with cardiorespiratory arrest. You'll get brain injury due to vascular disease. And then the last one's hemorrhage, right? The blood vessels are mechanically injured. So that can be in the setting of trauma, high blood pressure, aneurysms, or vascular malformations. Okay, a couple of terms clinically. You guys probably already know this. TIAs look like a stroke, but they go away on their own. So if it's symptomatic for less than 24 hours, it's a TIA. Strokes, the function generally doesn't come back. So greater than 24 hours is our time cutoff. This is the fourth leading cause of death in the U.S. So remember, AD was 85,000 deaths per year. This is 129,000 deaths per year. So this is the most prominent neurologic condition. Main reason is that you can get a stroke. Most people survive. Okay, so you will live the rest of your life with those deficits that you acquired. So you can have a stroke and live 20, 30, 40 years. Actually, one of my classmates, right after high school, she had a stroke at the age of about 20. So she's got a good 60 years. She's in a nursing home. It's actually pretty sad. She calls my wife frequently to talk, but she can't talk. So she just kind of sits there and says yes. She can say 3 words, yes, no, and she can drop the F-bomb. That's the only thing that's left. And I don't think she really knows what she's saying. Okay, so what are the risk factors for vascular disease of the CNS? It's actually similar to what we were talking about with Alzheimer's disease. Okay, so basically anything that damages the blood vessels puts you at risk for vascular disease. So here's our list of culprits: smoking, AFib, cardiac disease, so prior MIs, diseases of the valves, atherosclerosis, high blood lipids, diabetes. Okay, most important one of these though is hypertension. The cool thing about this is the one that's the easiest to regulate. So people will actually take their pills and check their blood pressure. It's easy to keep that one down. Okay, remember 15% of cardiac goes to the brain. Even though the brain only comprises about 5% of body weight, it's very hungry with regards to energy. If you disrupt the vascular supply to the CNS, you get energy and oxygen deprivation of the brain. The brain has 2 principal sources of blood supply. So there's the anterior circulation and the posterior circulation. Anterior is internal carotid arteries. Posterior is vertebral arteries. What's the system of anastomoses that joins those 2? Circle of Willis. Okay. Keep in mind that we show you these pictures of the Circle of Willis, and they all look the same, right? But every person's Circle of Willis looks different. So some people have very tiny posterior communicators and very large vertebrals and very large PCAs. Some people have very tiny PCAs and very large PCOMs. So some people will have an anterior predominant. Some people have a posterior predominant. Some people have very deficient anastomoses. Some people have very big, healthy anastomoses. All right. Just for your reminder, here's a picture of a typical Circle of Willis, and this is the dividing line. So everything from the vertebrals up all the way to the PCOM is posterior circulation. Everything anterior to that is anterior circulation. Okay. Each of these large blood vessels supplies a unique and predictable area of the brain. So ACA, the anterior cerebral arteries, supply the medial, parasagittal aspect of the brain. When I think about MCA, I just you can put your hands over the sylvian fissure, and everywhere your hand touches, that's MCA distribution. So it's the majority of the brain parenchyma. Most of the blood flow comes through the middle cerebral arteries. And then PCA is the occipital regions and the inferior temporal lobes. Okay, what's important here is this watershed distribution. So about a finger's width off the midline is the border zone between the 2. And if you have global ischemia, this is where you find necrosis. You can find it here, about a finger's width off the midline in the frontal areas. And then there's something called the triple border zone in the parietal lobes, where you have overlap between the ACA, the MCA, and the PCA. So sometimes you'll just get a big area of necrosis here. And that's a triple border zone infarct. Okay, so if you have global prolonged cerebral ischemia, I remember the number I was taught when I was a kid was about 4 minutes. So my parents always tell me not to hold my breath longer than 4 minutes underwater because I'd lose neurons. I can't hold it for more than about 10 seconds. So that's not going to happen. Yeah, but you start dropping out neurons. So neurons are one of the first cells in your body to die with global or systemic hypoxia and ischemia. The clinical scenario here, the most common scenario is patients requiring prolonged CPR. So you got a patient comes into clinic or is found down at home. The EMS or the people in the ED will resuscitate that patient, so they'll call it code blue. They will bring them back, meaning they'll get spontaneous heart function back, but oftentimes the damage to the brain is already done. So if that patient survives, they're at a very high risk of having a global ischemic injury. Okay. Also, patients with hypovolemic shock, so patients bleeding out in settings of trauma are at great risk of this. Anaphylactic shock, same thing. Okay, if these patients do survive, meaning you get the heart rate back, they're technically clinically alive, defined by the presence of spontaneous respiration and heart function, but they can have clinical brain death. So you define that by doing an EEG, and you have absence of cortical activity, so there's no electrical activity detectable in the brain. You can do a radiologic study called a perfusion scan looking for blood flowing through the brain. It'll be negative. Reflex testing for brainstem activity is negative, and then you turn the vent off, and these patients will have no spontaneous respiration. So I actually misspoke about 20 seconds prior. So they'll have spontaneous heart rhythm. You know, their hearts will work just fine, but they won't breathe spontaneously. So some of these patients. Now this patient, do you know this lady here? Yeah, Terry Shivo. So she's a prime example of this. So she had a cardiac arrest at home. She was down for quite some time, and they brought her back, and she actually lived decades after the incident. And she breathed spontaneously because her brainstem was still intact. But if you looked at scans of her brain, she had a functional brainstem. She had deep gray structures, so she had thalamus and basal ganglia. But her cerebral neocortex was completely gone. It was just empty space. So that's persistent vegetative state. So she didn't have clinical brain death, but she was in persistent vegetative state, and the difference was this spontaneous respiration. Okay, so let's talk about global cerebral hypoxia and ischemia. This falls onto the principle of selective vulnerability. So when you have global ischemia and global hypoxia, different cell types in the brain have different levels of susceptibility. Neurons are very resistant to ischemia and hypoxia, so the glia will survive with minimal injury, but the neurons will all die. So you'll find neuronal necrosis in these areas, but many times the glia are retained. So there's different levels of vulnerability based on cell type, and there's different levels of vulnerability based on location. So it depends on what areas of the brain are more metabolically active. So areas like the hippocampus, one of the reasons why it gets necrosis so early is because it's very metabolically active. Areas of the brain that are farthest from blood supply, so in those watershed areas, you'll get necrosis there early because it's farthest from the blood supply. And also, where are the excitatory neurotransmitters? So when you have ischemia, these neurotransmitters you start getting excitotoxicity. So the neurons start firing uncontrollably. And increased firing of cells in the region of NMDA glutamate receptors results in neuronal necrosis. And one of the areas where the greatest density of these NMDA receptors are is in the hippocampus. That's another reason why you get hippocampal necrosis with global ischemia. Okay, so what regions of the brain are most susceptible to a global injury? Classically, the one we teach most often is hippocampus. So CA1 is one of the regions of the hippocampus. CA means cornua monis, or Ammon's horn. I believe Ammon was the Egyptian god who called the sun over the sky every day. So he'd blow his horn and the sun would come over. And they thought the hippocampus looked like Ammon's horn, so that's where it came from. Another term for it is the summer sector, but that name is no longer in use. I just call it CA1. Okay, so in the neocortex, you can get watershed necrosis. So areas, remember I said a finger's width off the midline. You'll find necrosis there. Sometimes you'll have laminar necrosis, which means the deeper layers of the brain die in a layer, but the areas above and below that are retained. The globus pallidus is an area of selective vulnerability, so you'll find necrotic neurons there. In an adult, Purkinje cells can die early. Children have a slightly different distribution, so you'll find injury of the colliculi and the thalamus in a kid, but never in an adult. All right, grossly, what do I see in the brain? So this is a fixed brain, so this is all going to be fairly firm. A lot of brain examination is based on tactile, so just touching it, seeing what areas are firm, what areas are soft and squishy. This area here is going to be so soft that if you touch it too hard, your finger will just kind of break right through it. So this is an area of retained brain parenchyma. This is an area of ischemic injury, and this is a watershed or border zone infarct. Okay, so remember the ACA, blood flow is coming from here, this direction. MCA, the vessels lie here, the blood is flowing in this direction. This is just the farthest from both of those two. Okay, so clinically, remember one time whenever I was on surgery, my chief resident gave me the differential for acute confusion in a patient. Top 3 things for an acutely confused patient. Number 1, hypoxia. Number 2, hypoxia. Number 3, hypoxia. I think he was trying to make a point. So if you have a patient who's acutely confused, this is the first thing you need to think about is global ischemia. Pathologically, you see what we've already talked about, acute neural necrosis in these regions of selective vulnerability. So remember, watershed distribution and the depth of the sulci. So again, we're just talking about distance from blood flow. Blood flow is from an outside to an in. So you'll see necrotic neurons here. You'll see necrotic neurons here at the watershed. Summer sector of the hippocampus, sometimes brainstem, so you'll get substantia nigra necrosis. Remember in the kid, thalamus can be seen. This is that pseudoluminar or necrosis we were talking about. So sometimes, I've seen this just a few times, it's an unusual manifestation of global ischemia. What you get is, remember the blood flow is from an outside to an in, so the deeper layers of the neocortex are necrotic, and the superficial layers are preserved. This is due to distance from the blood flow, but also because these deeper layers tend to be more metabolically active. Okay, here's the concept of permanent global ischemia. So if you have a patient that has brain death, and we keep them alive on a ventilator, so you're feeding the patient, you're ventilating for them, they're technically alive because we're breathing for them. But remember, the blood vessels in the brain auto-regulate, so they will auto-constrict if, that auto-regulation is impaired because the brain is dead. So what happens is those blood vessels all close down, and even though the patient looks okay, like they're lying in bed, except for the fact they're connected to a vent, they don't look that bad. Inside their skull, their brain is autolyzing the entire time. So the longer they sit on the vent, the worse the brain looks. I saw a guy who was on a vent for a couple of months, and the brain was essentially liquid by the time they did the autopsy. So they had to take it out with a spoon. What you see grossly on these is the brains are globally edematous, and they're very dusky. And like I said, the farther it gets along, the more friable they get. So a very large, dusky, edematous brain. And if you look at the cross sections, it's very edematous. See, the shape of the brain starts to take on the outline of the skull. The ventricles are compressed and slit-like, and there's no distinct gray-white junction. So this is permanent global ischemia. We used to call this respirator brain, but then people started suing the manufacturers of the respirators, and they started suing the respiratory technician because they thought the respirator killed the patient. So just to avoid unnecessary lawsuits from people who are ill-informed, we changed the name. So now I just call it permanent global ischemia. All right, it's not the respirator that killed the patient, it was something else. This is just an end effect. All right, the spinal cord also has areas of selective vulnerability. So remember the lower thoracic cord which is the boundary between the vertebral basilar system and the artery of Adamkowitz. That's a border zone. So if you have global ischemia, sometimes you'll see necrosis just right in the mid portion. And if it's global, sometimes you'll see a band of necrosis that just forms this C shape between the posterior and the medial aspect of the spinal cord. And that's just because you have blood coming from the anterior and the posterior spinal artery, but then you get necrosis here in this border zone. I've only seen that once. Actually, most of the time at autopsy, they don't give me the spinal cord. It's much easier to take the brain out than it is to take the spinal cord. You have to saw off the entire column, lift it off, and pull the cord out. It takes about an hour. Nobody likes doing it. So it's very seldom I even look at spinal cords. All right, so now let's talk about localized cerebral hypoxia and ischemia. Okay, this is defined as an abnormality of a single vessel causing distal brain necrosis. So it tends to be localized. There's two different etiologies. I don't know why the textbooks keep dividing these into these two different etiologies, because there's a lot of overlap between the two and it's not a clean distinction. It ends up causing a lot more confusion, but I just put it up here because the textbook put it this way. So there's embolic infarcts and there's thrombotic infarcts. So in embolic, basically you have pathology outside of the brain that sends an embolism to the brain. This is supposedly gives you hemorrhagic or red infarcts. And then thrombotic is where you have disease of the vessels of the brain, which gives you this slower narrowing of the blood vessels as this atherosclerotic plaque expands. End result's the same. You get brain necrosis in the distribution, but these tend to be more pale. Pale meaning there's no hemorrhage in the area of ischemia. So just for the pictures here, see this area of yellow? Discoloration of the blood vessels, that's an atherosclerotic plaque. So if you touch that, that's going to be calcified and firm. Most vessels are nice and pliable. Take a cross-section of that artery, and you can see there's severe luminal narrowing. And then here's an H&E of that area, and that's the atheromatous plaque. So that's what we're talking about. So there's two types of infarcts. There's red infarcts, which are hemorrhagic, and there's pale non-hemorrhagic infarcts. These tend to be seen in patients that have embolic conditions, so stuff like mural cardiac thrombi that are shed emboli to the brain. And in these non-hemorrhagic ones, it tends to be seen in patients with atherosclerotic disease. Probably clinically, the thing that makes the most difference is in a hemorrhagic infarct, you do not give the patients thrombolytics. Okay, so no TPA for these patients. If you give these patients TPA, what's going to happen? Yeah, you'll get sued, the patient will die. Okay, because you're just like throwing diesel fuel onto the fire. Okay, and non-hemorrhagic infarcts, thrombolytics are indicated depending on how long it's been since the patient manifested clinically. And pathologically, we just see necrotic brain parenchyma without associated hemorrhage. And then there's a third type of infarct called a lacunar. Lacunar just means small, lake-like. So if it's less than a cm, it's a lacoon. These are seen in patients with hypertension, and they occur in fairly predictable brain locations, most often the pons and the brainstem, the pons and the basal ganglia and thalamus. All right, so here's a hemorrhagic infarct. What's interesting here is you can actually see the embolic inclusion of the middle cerebral artery. All of this tissue is dead and it's bled into it. Okay? So this is an MCA embolic infarct with extensive hemorrhage. That patient would or would not receive TPA. Yeah, you don't want to get sued. Sometimes you see bilateral parasagittal hemorrhagic infarcts. So if you look at the top of the brain, adjacent to the midline on the top, there's extensive hemorrhagic necrosis. This is seen in patients with venous sinus thromboses. So the dural venous sinus sits right up here. If it's thrombotic and occluded, the blood can't get out of the brain. And so all these veins adjacent to it rupture. So you get extensive hemorrhagic infarct because of impaired outflow. Okay, this is an old pale infarct. So what vascular distribution would this be in? Put your hand over the sylvian fissure. That's the area that's gone. Which blood vessel is that? MCA, very good. That's where I see most of these. MCA infarcts are most common. There's no blood seen with this. This is actually an older infarct because the tissue is just gone. It's not like it's soft and still there and necrotic. It's completely resorbed and you have a cavity left. All right, this is Lacunar. Remember, what's our size cutoff for a lacunar infarct? 1 cm. It's nice and easy to remember. Okay, and this patient most likely had what predisposing factor? Yeah, hypertension. Okay, marrow emboli. So patients with traumatic fractures of long bones can have marrow that escapes into the terminal circulation. So femur fracture, here's a classic scenario. We got a traumatic femur fracture. Bone marrow escapes from this, gets it travels up through your circulation and lodges in the blood vessels of the brain. Okay, so you'll have extensive hemorrhagic necrosis of the brain with widespread petechial hemorrhages, and microscopic sections will show bone marrow. So bone marrow is fat cells, megakaryocytes, and then the background is mixtures of myeloid and erythroid cells. Okay, if I was going to give you this, I'd give you a very nice leading history though. I'd probably show you this picture, and then you could get it from there. Yes, sir. It's the same thing. Yeah. Yeah, and I always get questions, well, what happens to the pulmonary circulation, right? Seems like the lung circulation would filter most of this out. The thinking is that they're small enough that they can actually go through the alveolar capillaries and then lodge into the brain, but we don't fully understand. Okay, so there's a lot of debate as to how it gets past the lungs and into the brain. Some people have patent foramen ovale, which would give you a method of bypass, but some people don't, and yet we still get fat necrosis, marrow emboli. All right, infarcts change with time. So one of the things I do as a pathologist, particularly in forensics, is to judge how long these lesions have been around, okay? So you try to correlate what you're seeing pathologically, and then you can track these things backwards and figure out how old the injury is. So histologically, about 12 hours is when you see red dead neurons. I'll show you a picture of those here in a second. And then some cytotoxic vasogenic edema. So this is the first abnormality. Similar to what you see in the heart, neutrophils are the first inflammatory cells to show up. So about 12 to 24 hours. Once the neutrophils leave, then phagocytes show up. So you get macrophages and microglia. First it's microglia that activate, then the macrophages arrive. They come in to chew up the dead tissue. They'll stay for months, so they don't just stay around for a little bit. They stay till their job is done, meaning that all the tissue is gone. About 1 week, you start seeing reactive astrocytes. And then about a month, somewhere around a month, you start getting cavitation, meaning that there's been sufficient time for all that dead tissue to be resorbed and carried away. And that will persist for the remainder of the patient's life. Okay, so here's a red dead neuron. Remember, neurons typically have big open nuclei with prominent nucleoli. These are just these shrunken, kind of fragmented, sad-looking nuclei. And then the nissle in the cytoplasm is that bluish granular material. It's just gone. So that's what gives it that red dead appearance. Next to show up some neutrophils. After that, it's macrophages. That's a terrible picture of macrophages. Just take my word for it. About 1 week, we get reactive changes. These are reactive astrocytes. And then about a month, you start seeing cavitation. Okay, so here's the concept of penumbra, which I find very interesting. If you can catch an infarct early enough and break up the clot, you can actually save a significant amount of brain tissue, and these patients will have partial recovery. So what happens is you have this area of ischemia in the MCA. All of this is going to be clinically manifesting. So none of this is going to work appropriately, but only a small portion of it's necrotic. So if you can stop the ischemia at this point, you will get recovery of function for this entire green area. But the longer you wait to reperfuse, the larger the zone of necrosis gets. And eventually, if you can't fix it, then this entire area will die. So if you can catch it here, eventually all you're going to have is necrosis here, and this clinical function will come back. So this is the penumbra, is the zone of subclinical or subnecrotic ischemia. And this is why oftentimes patients will get some function that comes back. All right, so what do we get in infarcts? I think we can skip this. Most of this is clinical, and we're starting to run out of time. Remember, we just talked about vascular dementia, so if you get enough of these, you can actually get dementia. Let's talk about some brain bleeds. That's a particularly dramatic example. So the most common cause of hemorrhage in the brain, regardless of site, is trauma. So anytime you see blood in the brain on a test question, first thing you think of is trauma. If you can rule out trauma, or if you find something else that's a better answer, go there second. But that should be your gut response. Any hemorrhage in the brain, trauma first. If you rule out trauma, hypertension is the second most common cause. Other causes of bleeding in the brain are ruptured aneurysms. Remember we talked about amyloid angiopathy and what type of patients? Alzheimer's patients. So they get amyloid protein that builds up in the blood vessels. So in an old demented patient, this can be a cause of bleeding. Ruptured vascular malformations, and then patients with coagulopathies. All right, so hypertensive vasculopathy can lead to just injury to all the blood vessels throughout the brain. It's clinically silent until it ruptures, so these patients don't have any manifestations. They need to take care of it before it ruptures, but if they don't, this is the terminal event. When we look at these pathologically, there's thickened hyalinized blood vessels. Sometimes you'll see Charcot-Bouchard microaneurysms. They're little tiny aneurysms that are too small to see by the naked eye, so you have to get lucky on your sampling. They're within the brain parenchyma. They're seen in small arterioles, most often in the basal ganglia, and rupture of these lead to basal ganglia hemorrhages. So they are seen in these branches of the basilar, or not the basilar, I think this is the MCA, so it's called these lenticulostriate vessels. And this is the most common location, is right here at the edge of the putamen. This is what they look like pathologically. It's just an area of weakness and deficiency of the media. The internal elastic lamina will be gone here. So the normal. This is where the normal blood vessel should be, and this is where the aneurysm is here. Okay, like I said though, I can never see this grossly. So basically if I have an area of hemorrhage in a hypertensive patient, I take a bunch of sections looking for this. I've only seen one ever. Okay, remember hypertension is the most common non-traumatic cause of brain hemorrhages. There's 4 common locations for these brain hemorrhages. Basal ganglia is the most common site at the lateral border of the putamen. Thalamus is also a common site. And then the other 2 sites are more interesting clinically. So brainstem, most often in the pons, is a common site. And what's interesting about that is it's rapidly fatal, right? Neurosurgeons will almost never touch the pons because it's hard to get the patient off the table. There's a lot of structures and they're vital for life. And every time they just barely touch the pons, the patients will crash. And so you can't go in and evacuate it, and oftentimes these are almost immediately fatal. Okay, the interesting thing about the cerebellum is that these are neurosurgical emergencies, meaning that if you can get the patient to the operating room and evacuate in time, you can easily save the patient. It's easy to do a suboccipital craniotomy. You don't have to bypass many vital structures, and you can get that blood out quickly. So brainstem is the most rapidly fatal. Cerebellum is the easiest to treat. Just some gross images of the same thing. So principle in pathology and neuropath is to look to the other side, see what normal structure is there, and you can tell what structure is affected. So here you just see an area of blood, look to the other side, it's the basal ganglia. Here's the pons, remember that's the most lethal. Here's the thalamus, obviously this is lethal. And then the cerebellum is the easiest to treat and to save the patient. Okay. Aneurysms occur at the break point, or branch points in the circle of Willis. These areas are normally deficient, and there's sites that are predisposed to develop aneurysms. Some patients have predisposing conditions like connective tissue disorders that predispose them to development. Regardless of whether or not they have a connective tissue disorder, the sequela is the same. So if these guys rupture, you get extensive subarachnoid hemorrhage, usually at the base of the brain. Okay, we will skip the clinical on these. What's most important about these is the most common sites. You follow the rule of 30s. So 30% occur in the junction of the anterior communicating artery and the ACA. So right there at that branch point, that's 30%. 30% occur at the junction of the PCOM and the middle cerebral artery. 30% occur out in the trifurcation, so out in the distal part of the middle cerebral artery. Okay, so 90% of these, by those rules, are going to be anterior circulation. 10% can occur anywhere along the posterior circulation. This is what they look like before they rupture, so sometimes you'll find them as just incidental findings at autopsy. This is what they look like after they rupture. So you have to dig through all that blood and try to find the site. So this is a 16-year-old guy just had a nasty headache, sort of the sudden onset, like thunderclap type headache, and he never woke up. So he lived for a couple of days in the hospital, and then this is what we got down in the morgue. So basically I had to peel all that blood back. I had to do it manually because it was formalin fixed. You couldn't wash it off. And eventually right here, so here's the anterior cerebral artery coming up this way. Here's the middle cerebral artery heading out this way. This is the ACOM. The ACOM is the shortest and most boring artery in the brain. It's about 2 millimeters long. Basically, it's just where the two ACAs touch. There's your ruptured aneurysm right there. This is my brush with fame. This is my finger. I had to put something back there so it would show up. Okay, there are giant aneurysms, defined as being larger than 2.5 cm. These present more like localized tumors, so they present with symptoms of mass effect. What's interesting about these is they very rarely rupture. So even though they're huge, they don't pop. All right, fusiform aneurysms are seen in patients with severe atherosclerosis. They're basically the same thing as an abdominal aortic aneurysm, or a AAA. So it's just atherosclerotic damage to the blood wall leads to progressive expansion of the vessel. And these also don't rupture. Instead of being a localized outpouching, essentially the whole blood vessel is expanded and enlarged. So see this whole thing right here? This is the basilar artery. It's huge, and it's full of atherosclerosis. Okay, we already talked a little bit about amyloid angiopathy, so this is seen most often in patients with Alzheimer's disease. What's interesting about these is that most of the other aneurysms that we've talked about have been in the inferior aspect of the brain. But if you have superficial superior hemispheric hemorrhages in an older patient, it's almost always amyloid angiopathy. So you look at the blood vessel, there's that amyloid deposition in the wall. Remember, our stain for amyloid is Congo red, right? So that's Congo red showing this positivity. If you polarize it, it turns apple green. Another thing that's helpful about this brain is, what do the ventricles look like? They're huge, right? So this is an Alzheimer's patient. This is an old demented patient with severe cerebral atrophy and a big lobar hemorrhage. All right, AVMs. So we have a couple of different brain vascular malformations. So there's cavernous hemangiomas, there's arteriovenous malformations, there's capillary telangiectasias. Of these, only AVMs have a high risk of rupture. Have you guys talked at all about AVMs yet? Or is this your first encounter with them? First time? Okay. AVM is defined as an abnormal connection between an artery and a vein without an intervening capillary bed. So basically it's a high flow shunt that runs straight from an artery to a vein, and you get this tangle of disorganized blood vessels, and there's always one large feeder vessel, which it could be any one of these guys. So this will come directly off a large artery, and there's just a ton of blood flow that goes through these. Okay, so the risk of rupture is very high. They can occur anywhere in the brain, but MCA distribution is the most common. All right, so I think this is the last slide here. Just as a reminder, there's many other causes of hemorrhage in the brain just due to medical disease. If you have brain hemorrhage in a very, very young patient that's otherwise healthy, think substances that raise the blood pressure first. So always cocaine and amphetamines. Unless there's trauma, then trauma is always first. All right, here's our other Far Side joke for today. That's what I felt like in the very beginning. All right, if you guys have any questions, got a tiny bit of time. I don't see someone else coming up here to kick me off the... Thank you.